And together, we will move mountains. And if they don't hear our message, then we'll just do it over and over and over and over 1,000 times again for you. And I'll rise up, I'll rise like the day, I'll rise up in spite of I will rise, we will rise, we will rise, we will rise.
Hi, everyone. My name is Michelle Zabel, and I'm an Assistant Dean at the University of Maryland School of Social Work and Director at the Institute for Innovation and Implementation. As you all know, this year of working virtually has necessitated some really creative approaches to conferences. We've spread the training institutes out over the last 9 months, just a few workshops each month. And I just want to personally thank you for joining in these discussions. These workshops have been so much richer because of you sharing your experiences and ideas to meet the needs of children, youth, young adults, and their families. So today, I have the exciting opportunity to remind you of some general housekeeping items. Even in a virtual world, they don't let me out of this part. Our workshops are being recorded, and your participation does imply consent. Also, please remember, if at any time you need help in navigating through the virtual spaces or accessing the links to workshops, we have a live help desk chat that is being monitored during the duration of the entire workshop. Our team is posting the link to connect with the live help desk in the chat box now. During all the workshops being offered throughout this series, I really want to encourage you to actively participate by using the chat to post your questions, any comments, and any resources you want to share with your colleagues. Our presenters absolutely want to hear from you, and we know your participation makes the workshops even better. We have staff monitoring the chat in Zoom and on YouTube, and they'll be assisting with facilitating the questions to the presenters and making sure that the presenters' resources are shared with you. So finally, there'll be an ASL interpreter available throughout the workshops. Interpreters will be shown on your screen, and they can be pinned for those who require interpretation. So you want to hover over the video and select the 3 dots. One of the options that appears is pin video. So by selecting that pin video, this video will now not move out of view. This summer, we are continuing the training institutes in a way that will allow you to take us wherever you go. So hopefully you're getting to take a break, a vacation, and get some relaxation. We're recording our summer workshops and releasing them each month so you can watch them anytime during the month that actually works for you. These workshops are on a wide range of topics, all focused on strengthening your skills as you support youth and families. While you're enjoying these summer workshops, we're going to be planning and working towards future training institutes, and hopefully we can all see each other in person. Thank you so much. Take care and enjoy your summer.
All righty then. So I'm hoping that everybody can hear me now. And thank you, Michelle, for your video introduction and everybody for joining us today. I am excited to present on the evolution of systems of care. And if those of you are fans of Buzz Lightyear, you'll appreciate the idea that we're taking systems of care to infinity and beyond. And how do we do that is sort of the genesis of what I'll be talking about, as well as talking about the kind of leadership that I think is helpful to understand as we continue our efforts to bring systems of care throughout the country. I will start by, oh yeah, there's me. And I think that I'm hopeful that I'm on presenter mode. Is that true?
Yes, if you can switch to slideshow.
Use slideshow. Any luck?
Yes.
All right. Well, I apologize. However, I think that it's definitely my issue and not the folks that we're doing this. So we're doing the best we can. So anyway, there's my picture. Yay. Most of you hopefully know that I'm no longer at SAMHSA, although I had a wonderful almost 16 years as the chief of the Child, Adolescent, and Family branch. And after I left SAMHSA, I became the executive director of the Hackett Center for Mental Health here in Houston, Texas. I'm excited to share that the Hackett Center for Mental Health has our phrase or our tagline of putting policy into practice. And we were established in 2018 as the first regional center of the Meadows Mental Health Policy Institute by a generous donation and endowment by Jim and Maureen Hackett, who have been involved in the mental health philanthropy world for many, many years. In fact, I will say that they've really been an inspiration to many to give back to the community, and they will talk pretty articulately about their own challenges in their own family and really identifying that mental illness knows no boundaries. And as a result, Jim and Maureen began to fund through their Hackett Family Foundation various kinds of programmatic services in the greater Houston area, and then became pretty convinced that the best way to move forward was going to be as a to create a center that really focuses on policy. We were created in the aftermath of Hurricane Harvey, which means that we really focused on issues related to trauma and grief and looking at strategies to hopefully infuse best practices into all the work that's being done, and then focusing on legislative and policy implications across the state of Texas and beyond, actually. So I represent the Hackett Center for Mental Health and the Meadows Mental Health Policy Institute. I will share as a little precursor to the conversation that, as I mentioned, that our purpose is to transform systems and influence policy through real unprecedented collaboration. We've talked about the trauma and bereavement, and we're excited to share that as of last September, we became the new home to the Trauma and Grief Center at the Hackett Center. This was a center that was established by Dr. Julie Kaplow in 2012 at the University of Michigan. And we have been fortunate to sort of blend our activities and bring the Trauma and Grief Center to become part of the Hackett Center and all the work that they do around services, supports, training, research on evidence-based practices. And so we're very much looking to address the issues. And boy, has it been a time to do this, particularly in light of things like COVID-19, the impact on our children and families, our adults, particularly in communities of color. And we're focused now on doing the kinds of training that's necessary to help with folks re-entering schools. So the Trauma and Grief Center at the Hackett Center is something that hopefully folks will want to check out. You can, I'll do this later, but you can check us out at www.thehackettcenter.org and find out all kinds of information about us. We also focus a lot on the systems of care approach and improving coordination across systems, and that includes health and education and juvenile justice and child welfare, and namely a real focus on integrating behavioral health into primary care, which I'm going to get into a little bit more later, as it's been one of the areas in my sort of post-SAMHSA career that I have felt really strongly about, that we should do a better job of integrating with primary care providers, because the data are pretty clear. 75% of the youngsters that have identified with a mental health challenge, the first stop, often in terms of that being 75% of the time, is with their pediatrician or their primary care provider. So it's very important that we do that. We also are looking at expanding our work in terms of research and institutional collaborations, and a focus on working with businesses on to increase the demand for effective mental health care. You know, it's important. We focus a lot, and I focused a lot in my government career on people that have been involved in the Medicaid system. And while that is critical and important, and often where Medicaid goes, so does, you know, commercial health plans, and that's a critical piece. We also know that 85% of us get our health care through our employer. And so how do we help employers do a better job at contracting for services and creating the benefit packages that we believe are as part of our values and principles are part of the system of care approach? So we're doing a lot of work in that regard as well. So that's the Hackett Center. So that's really what I wanted folks to understand. And now I want to shift gears and start talking more about the history and the impact of systems of care since the inception. So get ready for a little history ride. And if you have chats, some folks will talk to me about that so I can see what maybe folks are questioning, but that's where we're headed. As a reminder, you know, did you know that an estimated 13 to 20% of our children and adolescents at any given time can have a diagnosable mental, emotional, or behavioral disorder? And these probably right now are underestimates given the impact of COVID-19, you know, on children and youth. We know from studies, for example, at the Kaiser Family Foundation, that upwards to 40 to 50+% of our country has identified mental health as one of the things that has really impacted them as part of the pandemic, whether it's been directly because of issues such as trauma and bereavement, or loss of parental income, or, you know, increase in anxiety or social isolation, all of these things. So these are national aggregate data from historical studies that I think right now are underestimating the reality of what the pandemic has done. We know that around 20% of our young adults also have had a mental illness in the past year. And as you see, in terms of children, about 10% and 4 to 5% of young adults have a very serious emotional disorder or mental illness. Importantly, and I think another important talking point for folks that are on this call is that we've heard this idea that 50% of adult mental illnesses actually are manifested by the age of 14, and 75% are manifested by the age of 24. And that's led my agency to focus on this concept that mental illness is actually a pediatric illness. So that when we're talking about these data points and statistics and the importance of addressing mental health in children, we can also demonstrate very clearly through these data that mental illness begins for the most part in childhood and adolescence and young adulthood. And therefore, that's the age that we need to be putting more resources and, you know, in order to address both the mental health promotion, preventing mental health disorders, as well as early intervention and ultimately treatment when necessary. And unfortunately, the data are also clear that over half of the children with mental health needs do not receive services at all. That number could actually be increased. Now, I am a little hopeful that we've done a better job as a result of COVID. Some of the, I'll say, the outcomes that we want to continue with have to do with things like telehealth services and increasing access and capacity. So taking our data, our stories, the information, focusing on the importance of, as we used to say, you know, caring for every child's mental health. So that's a critical piece to all of this, and something I wanted to make sure that we start with as a way to help people focus attention on this critical issue. The World Health Organization has actually described mental health in terms of problems in youth that are likely to become some of the most significant challenges that we have in the 21st century. So Now I want to talk a little bit about the founding of systems of care, and really the history. It started before my time, that I was with SAMHSA back when I was still with the state of Connecticut, and trying to work on creating systems of care, when we had Jane Nitzer's book as part of her doctoral dissertation, Unclaimed Children. And that particular book led to this idea that we needed to do something desperately to address this failure that we have had, the fragmentation of services. And Jane really, and she had passed away a number of years ago, but she was an inspiration to many of us, that helped us to see the importance across all of the states, which led to Congress appropriating funds in the mid-1980s for what was originally called the Child and Adolescent Service System Program, CASP. Many of you may have heard of that term before. I was the beneficiary of a CASP grant when I was with the state of Connecticut. And really those were looking to create plans and to develop the infrastructure that was necessary really to create these kinds of systems of care. What was the idea? But at that time, we still weren't really sure what was happening until 1986, when we had the first monograph that defined the philosophy and services comprising the system of care approach. There were updates to this, as you see, in 1996, and when I got to participate in 2010. And we're going to talk a little bit more as we get into the chat box. We'll get a link in there that just this past week, we published a new update, thanks to our colleagues at the Innovation and Implementation Center at the Institute, that really continues to look at evolving the system of care definition and the frameworks around all of this. And I'm really grateful. Beth Stroll and Bob Friedman published that original 1986 monograph, updated it in 1996, and then we worked on sort of this evolution. And I think that's an important concept here, because it's critical that we're not stagnant and complacent in what we do, that we take lessons learned and continue to update what we think is going to be through our lessons learned, through our data points, through what we've heard, especially from our young people and our families, what our next iteration is for systems of care. And so that said, in the mid to late 1980s, the monograph was published. We had the CASP program happening, and it became clear that in order to take the next step, we couldn't just create like plans. We had to actually implement something. And that's where in 1992, Congress passed what we call the Children's Mental Health Initiative, but the Community Mental Health Services for Children with Serious Emotional Disturbance and Their Families program. Of course, that's a pretty long name. Thank you, Congress, which is why we shortened it to the Children's Mental Health Initiative. And initially, this started with a $4.9 million investment as a demonstration program. I will say that in 2000 and what was it, 19, when I left SAMHSA, the program had been received bipartisan support through all of those years, including the 15, 16 years that I was at SAMHSA, and the program had actually had a budget at that point of $125 million. So from 4.9 to 125 million. And while that is impressive, and I remind people that that is a significant and bipartisan approach to children's mental health, it is still a drop in the bucket when it comes to the kind of funding and services that are needed across the country. So we often talk about the creating systems of care using the SAMHSA grant program as leverage points as far as moving forward. Now, many folks, I think it's still important that we define and help people understand what exactly a system of care is. On the slide here, you can see it is a spectrum of effective community-based services and supports for children and youth, young adults. We've expanded to young adults originally the program was served up to 21. We were able to extend that through the age of 21. So really it is a young adult program. I hope one day we go up to 23 or even 25. And these are for youngsters that either have or are at risk, significant risk for these kinds of mental health and challenges. It's about organizing into coordinated networks. Not any of us can do this alone. It's about building meaningful partnerships with families and youth. And it's about focusing on culture and language and really addressing that, what may work in one community may not work in another. What works for one population may not work for another. And that became a real hallmark of systems of care. Our approach to cultural and linguistic competency, I think, has been something that really has focused efforts across the country. I think that it's really significant. And of course, we do all this to help folks thrive at home, in school, and in the community, and of course, throughout life. A system of care is a framework. It is an approach to a global service system. So I think it's important that this concept not be understood as a prescription or a quote model insofar as that. It is a guide that is intended to be flexible. It's intended to be creative and adaptive to community needs. Within a parameter, within both a consistent framework, a consistent philosophy, and also the values that people hold near and dear. We've talked about family and youth-driven. We've talked about cultural and linguistic competency, evidence-based. The idea that we bring our clinical excellence and really do a good job of collaborating. And that's what it is. It takes a village to make this happen, and systems of care really do focus on ensuring that that village is something that we're going to do. Now I'm going to shift gears a little bit and sort of, as a backdrop in our history and how we've come to this point. Is really critical. So as we talk to policymakers and others about, working on systems of care, expanding, enhancing, all of the things that folks out there across the country are doing, and certainly here in Texas, we have a statewide system of care approach to all of this, and I think that those are critical pieces. I see that. What are the data? And we need to bring the data points, into the mainstream so that folks that are maybe skeptical or need to be convinced that the philosophy is important here. What is it that we can tell them? Well, certainly, number one is that when young people are enrolled in a system of care, they have significantly improved outcomes, clinical outcomes. And I think that, number one, we've been blessed and fortunate over the years to have a robust national evaluation. I hope, and I really will be personally advocating that we continue to get back to that kind of evaluation approach, because it has helped us both course correct over the years, as well as provide the data necessary to continue expanding, because systems of care work. I like that. It's kind of a bumper sticker approach. And how do we know that? Well, number one, we know that there are improvement in behavioral and emotional symptoms. We know that levels of clinical impairment are absolutely reduced, and that young people, suicide, I think, is one of the most tragic events in anyone's lives, and systems of care save lives. There are fewer suicidal ideation, fewer suicidal thoughts, and fewer attempts as compared, to other young people with similar problems, be it in, various communities. And these are data that came from our national evaluation over the course of many, many years. And I think it's important that people really do understand that when compared to young people that don't have access to systems of care, the young people that do see significantly improved clinical outcomes. Next is that young people involved and after enrolling in a system of care are less likely to be arrested. In fact, young people that have been in a system of care are less likely to have negative law enforcement contacts. Sorry about that. I think my computer is having a moment. That less likely to have these law enforcement contacts, and including less likely to be arrested. One of the things that is really key if you're working with your juvenile justice system is to bring to them data about less juvenile justice contacts, negative, less likely to be arrested, and less recidivism into places like juvenile detention centers. In my time working across the country, the judges used to tell me how appreciative that they were of systems of care because it gave them an opportunity to divert youth from having to go into higher levels of restricted care. So we've been very successful, and many of the systems of care that were involved with juvenile justice have actually been sustained in really nice ways because of these data. So it's another really important data point to bring to your policymakers and folks to help them understand that engaging in a system of care approach has these positive outcomes. Number 3, after enrollment in a system of care, children are able to be treated in these less restrictive levels. Well, so ultimately, I think what we can say is that not only do systems of care save lives, improve outcomes, they also save money because it's expensive to put young people in these higher levels of care. And I need to say that I am a believer in having an entire array of services. We need all levels, from high levels of promotion and mental wellness activities all the way through residential and hospitalizations when necessary. What we don't want is, however, is to put young people into these restrictive levels of care unnecessarily, or to leave them there for great periods of time when they should grow up in their homes and in their families. So this is a really important idea that by putting kids in the right setting in the community, it actually saves them as far as from emotional strain and stressors, and it saves the system all kinds of money. Another important outcome has to do with our friends in the education system. Systems of care result in improved educational outcomes. We know this because we see higher rates of attendance at school. You got to be able to go to school to benefit from school. And so having high levels of attendance rates and improvements in attendance is a first step. It's not the only step. We also need to see better grades, which we do in the system of care, and fewer suspensions and expulsions, and literally increased graduation rates. Our colleagues in the education field also appreciate, similar to juvenile justice, and then also in terms of child welfare and being able to maintain placement stability. They all feel this, that this works and that we can make a huge difference. So again, whether you're talking across all the different child serving systems, we have data points that really demonstrate why this is important. So when you do this, talk to juvenile justice, child welfare, education, pediatricians, everyone, and bring data points to help them understand that by doing this, you actually see better outcomes. And here's a great slide talking about sort of the whole overview of the impact of systems of care. Really, and I learned this from my colleagues in Oregon, who talked about the ultimate outcomes for young people being that they're healthy at home, in school, and they're out of trouble. And that, to me, really summed up the importance of this idea, at least, that that mental health cuts across all of those systems. So for child welfare, we have to give mental health away to all of these systems and give that away so that young people stay at home in the child welfare system, and they don't have to have placements, or in school and doing, and graduating. And of course, law enforcement appreciates that we're able to help young people stay out of trouble. And again, it's really the system, and then deciding what kinds of practices and evidence-based or practice-based approaches that we have. So if you're in a juvenile justice system and you want to bring MST, multi-systemic therapy, into the system as part of it, those are things that systems of care really does, I think, a really good job with. So again, my presentation really is about, sort of an umbrella, a funnel system to talk globally about the issues of mental illness and mental health in terms of prevalence rates, and trying to get the word out there and spread the importance to various people, and then really the data about systems of care. And again, helping everyone to move forward as they do this. And then we start thinking about the future of systems of care and how the approach has evolved, and then how it continues to evolve. And this is where I get to plug our new monograph that just came out last week. And I want to thank Michelle Zabel from the Institute for Innovation and Implementation for publishing this and spearheading it through the process. I also want to commend Beth Stroll for her persistence in doing this, and our former medical director at the Center for Mental Health Services, who is now with Shepherd Pratt, Justine Larson, and worked really hard on this idea of where we've been and where we need to go. So hopefully in the chat box, there'll be a link to this if you haven't seen it. Also, shout out to Scott Bryant Comstock and the Children's Mental Health Network. In order to, they've shared this in their last Friday update, and we appreciate that. So please download that, use that, ask questions about it. I think that, again, the idea here is to take what we're doing and move it to the next level. As I like to say, move it to infinity and beyond. And I love that, because our oldest grandson was really taken with Buzz Lightyear at one point. So kudos to Logan for making me feel like that was a great approach to this presentation. And the key to this, and I think what you'll see, is a couple of really critical components around the evolution of systems of care and the definition. And this is not without its questions or challenges, but I'm not going to read the whole thing. What I'm going to say is that systems of care was originally developed in order to identify and care for the most seriously ill children. And that is still a critical piece. It's a critical part of the grant program, and it's a critical area that we have to focus on. And as you can see here, this is the definition that has been tweaked over the years, really to focus on that. We are also now saying that as part of the system of care, and it doesn't mean that all services that are provided, say, to the youngsters that have the most intense acuity levels or significant clinical issues, need to be provided to everyone. Our colleagues in the education world talk about a multi-tiered system of supports, or MTSS. And that kind of an approach really is important in our mental health world, that we look at the different tiers of approaches. And we also need to understand that to have a true system, an array of services that meets everyone where they need to be met, we have to incorporate mental health promotion, mental illness prevention, early identification, and then, of course, early identification hopefully leads to early intervention. And then, of course, if necessary, to types of recovery treatments to address the needs of young people and their families. So I think one of the biggest evolutions of systems of care, at least in my experience, has been to say that we have to take a more comprehensive approach, and also a more comprehensive approach to our partners and our partnerships. And that's really where we stand. I'm not going to go through this, but you can see the guiding principles have changed, well, not changed, but have been added on. I want to highlight, of course, because I now have the Trauma and Grief Center at the Hackett Center, number 4, a trauma-informed approach as well. And also looking at the idea, number 11, taking a public health approach, and also the importance of equity in what we do. I mean, obviously health equity, mental health equity is a critical piece, because we know that disparities in care cause additional, poorer outcomes in folks. So that's another area. We're really focused on data-driven and accountability and rights protection and advocacy. So we've expanded some of these guiding principles as we've learned lessons over the years. We also know that we have to expand and evolve our infrastructure. And in the document, in the monograph, we talk about those structures and processes and how that oversight needs to happen and where all of this fits in, and really a robust provider network and the integration between health and mental health. Those are the things that I think that we would like to see more depth, if you will, delving deeper into what needs to be done around structures and processes so we keep evolving the system of care. Expanding our service array and our components. As I shared, we have our core elements of systems of care that were outlined. If you don't recall, the 2013 informational bulletin that we reflect on, that was between SAMHSA and the Centers for Medicare and Medicaid Services, that talked about what Medicaid will cover, that included things like mobile crisis and stabilization and wraparound or intensive care coordination, in-home, respite, family and youth peer support. And then, of course, trauma-specific treatments. And now we're adding the concept of telehealth as a component in a service array as part of that, as we've learned the critical needs for that. And it's not a perfect system. It is important as part of the overall service array. In some cases, that's important. In other cases, we might not want to do telehealth for various reasons. We should have the availability, and it should be funded, both telehealth and telephonic kinds of services. So this is a slide that's very busy, but I included it just because in the monograph, we really do look at the service array and identify various services that we think need to be part of the system of care, either paid for in various ways through Medicare, Medicaid, that is, or commercial insurances, or through grant programs or philanthropy for that matter. So now I want to, again, my homage, how do we take systems of care to infinity and beyond? I know I didn't do justice to that, so I apologize, but I do love this, and I think it's adorable. So anyway, the first thing, and this is different than folks that may have heard me talk about these things in the past. I've sort of changed it up a little bit as I feel like I've evolved and I've learned, and if that's one thing we need to do is evolve and learn. First is primary care integration. Like I said, mental illness is a pediatric illness. 75% of our youngsters, the first stop in their mental health journey is often the pediatrician. So we've got to do a better job of engaging them. In the adult world, they see things like collaborative care, where there's outplacement of mental health in primary care settings. In our world that we've looked at primary care and behavioral health integration, we know that there can be primary care or health care within behavioral health settings. And that is a critical piece. Our mind and our bodies are connected. But we've often treated the brain differently from the body. And that's been our thing. We've kind of cut the head off and said, okay, well, we have a mental health system and then you have a physical health system. And I think that systems of care going forward, we've got to do a better job of integrating. And I have a personal example for this. If you're a little squeamish, I'm going to ask that you close your eyes for a little bit. You're going to see it anyway, probably, but this is a personal example of how the systems are different. So here's me. So this was literally just a couple of years ago, right before I took on this new role, and I had a physical health crisis because I woke up one morning and I looked like this, and you can see that is not the way my eye usually looks. So upon my initial anxiety about, oh my goodness, what's happened to me, what's going to happen next, what did I do? Well, so you can look now if you decided to close your eyes about my eye. But what I did was I called my primary care doctor, and he actually asked me to text a picture of my eye to him, hence why I have a picture of my eye. Not that I really wanted to do that, but he said, you need to come in. So I went in to see him, and while I was with him, a little scary, he brought me into his office. He takes this book out and he starts looking through it. He says, I'm really not exactly sure what's going on with you. So what does he do? He calls an ophthalmologist. in a specialty care situation. And he got me an appointment with the ophthalmologist that afternoon. And so I go to the ophthalmologist that afternoon. And if you notice, I just put an X over inpatient care. Why? Because the ophthalmologist treated me and kept me out of the hospital. And I ultimately got better. But that was the way the physical health system worked. Very different than in the mental health system. What do we do when we have a crisis? Well, I bet many of you, like I did in my practice, have an answering service that says, if this is an emergency, contact 911 or go to your local emergency room. I mean, really, why can't we have a system like we have in primary care? Why is it that we immediately send somebody in crisis to an emergency room? Or worse, why do we call law enforcement into it and have people end up in jail, which ultimately is a somewhat de facto place where people with mental illness may end up. And so what has happened is we've created this fragmented care, when in fact, we could blend this much better if we were doing all of this through primary care, through the mental and physical health connection, so that rather than sending somebody to the emergency room, we actually have the ability to provide crisis services. And many places do. So don't get me wrong, but many places don't. So, if you have the ability to have a mobile response unit, if you have social workers or psychologists or psychiatrists that are backing up police that are called out on mental health emergencies, these are great strategies. We just need to see them expanding all over the country. So the ultimate idea is to have an integrated system that we put the head back on the body and all of these kinds of things. So the best mental health care is just like the best healthcare, because you cannot have health without mental health. End of story. And then the concept of doing this is integrated across all the different child serving systems. The Olympics is coming up and love these rings. So we have to integrate and sort of the idea of all the rings sort of having an intertwining approach to it, so that we're all working together in an integrated way, rather than all the silos that we've created. I said this, we have to mental health cannot be its own silo. It has to be in education, it has to be in child welfare, it has to be in juvenile justice, has to be in primary care, et cetera, substance use. All of these things, so that ultimately it's not a silo, it's one big siloed approach together, if that's the right word. Number two, I think that systems of care need to start taking more of a public health approach. I want to thank, and I know that Joyce Sebian has actually joined us today and as an author on this, along with the rest of the folks here at Georgetown, when we were trying to expand the idea of systems of care, that mental health in children has to be through a public health lens, this whole concept. If you're interested in that monograph, please jot down this or send us a note. We probably have some more left, or you certainly can download it from Georgetown. A conceptual framework, and particular thanks to John Miles and that team for helping us to think through what this means. This is still relevant today. The whole concept of the public health pyramid with the hierarchy, the very intensive needs of support at the top, but most folks needing really a much less complex intervention, that 80% at the bottom. And how we do this together is by integrating across all of those different systems. Thanks to Sheila Pyries around this for this slide, and building this systems of care as it relates. And again, very consistent with other approaches like education's MTSS, multi-tiered system of supports. So we have to apply this public health approach. For me, in addition to all this, it's important to highlight this critical piece about schools and school-linked services. Number three, we've got to get back to our core values, and that would be family and youth-driven, cultural and linguistic competence, and being community-based. Really important. And why I say that is that there will always be the need for high-end hospital and residential. What we need is to be able to help our colleagues in that area with expanding intensive outpatient services. One thing that my colleagues in residential and hospitals tell me is that it's hard to get kids out into an aftercare program where they have the right services. And so that's an area that we have to sort of refocus on, revisit, re-energize as we're thinking about the evolution of systems of care. I mentioned that, and then I'm going to strongly mention the concept of family and youth-driven care. You see the definitions on the slide. I've had the great fortune in my work to work with folks from the National Federation of Families and Youth Move and Youth ERA and FREGLA, the family-run leadership organization, and a host of folks from all over the country who are committed to making sure that families and youth participate in the development of their own treatment plans and care, and also focusing on helping with improving the system. And I think that, again, using whether it's grant dollars, philanthropy, in making sure our families and youth are not just at the table, but they have meaningful, authentic roles as part of our system is a critical value. When we do that, as you know, that the family and youth engagement and leadership will improve, and it can occur across every area. And people have said to me, well, but folks, the young person may not understand, the research. Well, then we can teach them, or social marketing. Yes, we can all do that. It's one of my favorite lines. How many of you out there are social marketers? And so you should all be raising your hand right now. We are all social marketing experts when it comes to our children and our children's mental health. So these are just examples of youth leadership. And then finally, as part of our core value, we have seen, and I'm just going to say this, that I think the country has had challenges in terms of racial injustice. And after the murder of George Floyd, as we know now that it was identified as a murder, I think many of us said it was a murder from the very beginning, that we've had an increased awareness of the impact of racism on mental health. And I think that it is incumbent on the next evolution of systems of care, not just to embrace diversity and use cultural and linguistic competence, but also to think about things like, what does it mean to be culturally humble, a cultural humility approach? Systems of care has been at the forefront of this from the very beginning, with the original monograph by our colleagues, Terry Cross and his work that helped to shape the field of cultural competency in children's mental health. And it's time we do that again. It's time that we focus on this impact of racism and injustice and disparity on our children and youth. And I really, I can't stress that loudly enough. Next is our strong partnerships, public and private partnerships. I think that those partnerships are critical in an area I wish I did more when I was at SAMHSA, and one that I'm going to keep pushing on now. One that is particularly important around faith-based organizations. I'm proud of some of the work that we've done there. Partnerships with residential so that we can continue to right size and right time the residential intervention. An area I think we have to do more with is the business community, and having businesses understand that by providing a better benefit package for adults and families, that actually it improves their productivity levels and helps them have less presenteeism and absenteeism. In other words, people are absent from work because they have to care for their child's health or mental health care. And sometimes when we're at work and we're stressing about things, or having to deal with the school, or having to address whatever issues maybe arise, that we may be there and present, that it's not really a good productivity situation. So that's called presenteeism. We've got to get to our managed care organizations and health plans and really continue to work hard at showing them that these benefit packages must include the stuff that was on that former slide about all those different services. It's a hard sell unless our state agencies and our businesses are going to force the issue. So it's helping them to do that. I also think that another area is philanthropy and foundations, and how we can do a better job of filling in the gaps through the graciousness of people like Jim and Maureen Hackett and others that have foundations that are willing to help us in our cause. So that's just a thing. I have two things I want to share related to this. One is a plug for my friend John and the open table approach, which absolutely has been demonstrated to be effective in helping faith organizations to take a mental health approach. If you're interested in more of that and how faith-based approaches can be brought into systems of care or into a community, and how all faiths benefit from this, and creating these, quote, tables that are essentially wraparound teams. John Vandenberg, one of our original founders of the wraparound approach, has done research with John Katov in Open Table, showing that this is an approach that's really effective, continues to engage people in their in relationships, and helps people come out of poverty and helps folks improve their mental health. So open table. The second one has to do with what we started a number of years ago called the Building Bridges Initiative. If you're not familiar, you can use this website to identify all these resources around what it is that is residential best practices and how we support each other in creating a system of care and wraparound approaches. Loads of resources, tip sheets, and self-assessment tools. So I mentioned these as examples of stuff that's already out there that we can use already. And then a fifth area that I think we could do a better job of pushing the envelope on is around measurement-based care. Now, I originally titled this slide evidence-based practices or practice-based evidence. And I think that in some ways I worry that has its own connotation. And so my agency is now using the framework of measurement-based care. And what we mean is that whatever care is being provided, we need to track the symptoms and the outcomes. It's pretty simple. You know, I don't know about y'all, but when I go to the doctor's office, every time they take my blood pressure, well, I mean, we should be having those kinds of questions, whether it's a brief questionnaire. Some of you may be familiar with the patient health questionnaire, the PHQ-9, or things of that nature that can be added to appointments and stuff so that we can literally track how folks are doing and course correct if we need to. So you can see through all of this slide that the use of measurement-based care, or the repeated use of validated measures to track symptoms and outcomes in our clinical settings, is a critical piece. Now, obviously that can come with evidence-based practices or practice-based kinds of evidence that we're focusing on, services that may have preliminary evidence or promising practices. All of them, which is why I don't want to just focus on evidence-based practices, all of them should be using a measurement-based care approach. And that's an area that I think we as a field, as a children's mental health field, continue to focus on as we evolve systems of care. So with all that said, checking my time, and I think I have about 20 minutes left before we open up to questions or comments about how do we take systems of care to infinity and beyond. And for me, and this is not a surprise to many, I think it's around some important components of leadership. And, you know, my friend and colleague, Ellen Kagan, has lots to say about leadership, has taught me about a lot about leadership. And I think that I'm pushing that approach because it's really critical for all of us to consider this. We created although I think the book I don't know if it's hard to get these days, but the leadership equation, where we talk about our values, our beliefs, and our actions, and how all of us are on a personal leadership journey, no matter where you are at in an organization or a hierarchical structure. We all have the ability to have leadership, whether you're a frontline staff, and you can demonstrate leadership by demonstrating that, you know, you're role modeling, strengths-based, or looking at collecting the data and for accountability purposes, and making sure that parents and caregivers and youth are included and stuff. I mean, those are things that can be done, across all of this. Or whether you're in a policy or a government or management position, and you can use your leadership to address concepts of contracting and language that can push the system, and benefit designs, which I'm harping a lot about. I just think it's really critical, because if it's not written in a contract, it's not going to get done. If we don't ask for it to be measured, it won't get measured. So the idea is that we have to be out front of these things. And so at all of these levels, we can provide leadership. And I have a great story around this. If you come to our leadership trainings, you may have heard me talk about it before, but this slide represents the Boston Philharmonic Orchestra and Benjamin Zander, who was the orchestra leader at the time that this happened. And the component of CQI, or quality improvement, he called the measure of leadership, and he talked about the white sheets. The white sheets of paper was what he put on each musical stand at the beginning of each rehearsal, because he was really not happy with the way his orchestra sounded, and he wasn't sure why. And you know what? I've been in that position. I bet you have too, where it's just not right, but we don't have all the answers. I used to tease that if I had all the answers, my books would have been on Oprah, and we would have solved the problems already. Not happening. So if you don't have the answers, what do you do best? Well, quality improvement dictates that you ask people for feedback. My favorite feedback often comes from youth and families themselves. In Mr. Zander's case, he asked every person in the orchestra, from the first chair violinist to the third chair oboe, and he asked them to give him feedback about how to make the orchestra better. And by doing that, through these white sheets, he actually got great advice. And he called it leading from any chair. And that's what I think is a critical piece here, is that all of us, no matter what chair, if you're in a residential facility, I've seen the, people say, okay, well, the leader is the CEO or the clinical director. Yeah, well, on the ground, the leader may actually be the guy who cuts the grass, right? Who has relationships with the kids, or the person who's, doling out lunches, or you just never know. Leadership can come from every point of contact. And that's what we have to consider. And we also have to understand about what those expectations of leadership are. So for example, yes, there are a few people in the world whose leadership, changes on a vast scale. I say to my new staff, my new interns, that they have a 3-word job description, which is simply change the world. And it doesn't mean, having to become president or, something like that, because the expectations of leadership, if you do incremental steps, even small changes can make huge impacts. And so we have to understand all of us are at different levels in different areas. But for me, perhaps leadership is influencing my own family or my own agency, or my own committee, versus if I'm the CEO, maybe it's a bigger area of influence. But I think that the point is that we all have leadership capabilities, and that we should remember that even small changes and small increments can make huge differences in people's lives. We also have to take a strengths-based approach. I get very challenged when all of you folks talk about all the problems and all that. Yes, we have significant challenges ahead of us. And we have to develop that other people don't have to be wrong for us to be right, that we can take this right versus right decision making. So there can be multiple avenues. You know what? I got to go to the grocery store over the weekend, and there's probably 3 or 4 different ways to get me to the grocery store. Either way, I get there. So there's just different ways. There may be a right possible answer here. And one of the stories I had, which was taught to me by a very good friend from Connecticut, was if you ever get stuck in a situation, and this is hard, I've done it 3 times already, I've been counting today, is that try to replace the word but in your conversation with the word and. It's very simple, because if you're in a meeting and you're like, hey, Gary, that was a great idea, but, well, what does that do? It sort of negates everything else that I had just said. So what I suggest is that if, and it's kind of hostile and antagonistic, what we need to do is to say, Gary, that was a really good idea. And I have this other, either approach or addition, and it's a strategy that people can use where we are not just right and wrong. We can both be right and we can do it together. And so I think that's important. We also need to create teams that create discomfort. My agency right now is going through a pretty difficult time of talking about, racism and the impact and what this means from a health equity standpoint. Well, if we didn't have tough conversations, we would not take that next step. If we didn't put together residential treatment providers, families and youth, systems of care leaders, and community providers in the same room at the same time, the Building Bridges initiative would have never happened. To say that it was uncomfortable, yeah, but it's important. And then what we really need to do, and I love that Scott and the Children's Mental Health Network, focuses on the optimistic advocate, because a former SAMHSA administrator, Charlie Curie, in response to me probably being a little bit annoying, once told me that he needed me to be the aspirin and not the headache. And I, to this day, remember the importance of him saying that. Of course, my first response was, oh my goodness, he's upset with me. And then it was, he's so right. I need to come with ideas and solutions and not just complaints about what was happening. And that's a focal point for all of us. Now, all of that being said, I've learned a few things in this journey of leadership that I wanted to share with folks. I actually will be honest and tell you, I had originally planned to share this last year at the Tampa conference, and it got canceled. So I'm interested in feedback about these things, but it came from some introspective thoughts that I've been having about my own journey. And so some of this may resonate with you, some of it may not. Take the things that resonate with you, and then the other things that don't, well, just push them to the side and don't feel that you need to do this. It's about what I've learned and how I think that leaders and we can work on our own selves, because addressing our own needs, self-compassion is a word that I've learned through my colleagues at the Trauma and Grief Center, that is a critical piece if we are going to be successful in helping others. As they say, when you board a plane, put on your mask first before helping others, because you have to be okay first, and that's the critical piece. So I'm going to share a few of these. The first thing is that remember that the difference you make really does make a difference. And I say that because, sometimes people get caught up in this idea, well, I need to do, some major event or something. And really it is that sometimes just helping that one person or answering that one phone and saying, how can I help you? It actually does make a difference, and people resonate with that. So remember that even those small changes or small things that you do can make a real difference. I also learned that burning the midnight oil is different than burning the candle at both ends. So I will admit, there are times in my history and career where, I've stayed up late or gotten up early and, had a major event to work on or a paper or whatever. Often it was some kind of a close of business requirement, fire drill for the government of some sort. And that is different because, passion and dedication is the reality. The problem or the issue or the concern comes when you burn the candle at both ends and it burns you out. So know the difference between what it is that we're doing. I also learned that it's good to have an open mind, an open door, and to ask open-ended questions. And I say this because there have been times, probably within myself, actually, I can say yes, as well as by interactions with others, where I don't feel always that we come into this with an open mind. We have our ideas or we're going to, understand things. And the truth is that it's hard sometimes to have that open mind because we believe we're right about something. And it's been often when somebody has helped me to see the other side of the equation, and it doesn't always mean I've changed my mind. It means, though, that I can appreciate somebody else's perspective of something and maybe change the dialogue a little bit to be more conciliatory, using the and rather than the but. I also have found that maintaining an open door policy, and I'm sure probably almost all of you do, is really critical. I want people to be comfortable to share with me what they think and feel without fear of repercussion or retaliation, because it's the way I have learned the best. And then asking open-ended questions. You'll learn this if you testify or deal with lawyers in various ways, that a yes/no question doesn't get you very far. It just easy, simple answer. So help me understand. this, or, rather than, well, do you want me to do this? Yes or no? So, I mean, those are the things that have helped me as I hope a manager and a leader to do this. Of course, I also remember to have an open table, but that's my my little plug for the faith-based work. Remember that taking the high road is better than being on a high horse. So what I mean by that is that, yeah, sometimes I have felt that I am right and I am advocating for things. Some folks have heard me talk about what I learned from a consumer one time. It talked about, yes, I'm a bureaucrat, but I advocate, and I advocate for things within, the government or within agencies, or et cetera. That makes me an advocrat, which I just love the idea. So rather than being right and righteous in my thing, so taking the high road, how do I address this, rather than just simply being on my high horse? Another is that you don't have to be from the royal family to get the royal treatment. And this is really important to me, because I think that how we treat everyone across the board, across the hierarchies, whether it's linear in terms of, or vertical or horizontal, it doesn't matter. Every person deserves respect and to get the royal treatment. And when we do that, and when we reflect and demonstrate that to people, that it goes a long way. And I have found that when I've tried to help people know that their voice was meaningful, that their opinions were meaningful. They didn't have to be the assistant secretary or the CEO of an organization for me to listen to them. I could listen across the entire gamut. So remember, the royal treatment should be given to everyone. Just my observation. I also learned in my course of time, especially after 25 years of government, what matters most. Words matter. Language is really important in how we demonstrate things. And yes, while we may make mistakes sometimes, and we have to address that, I've made several in my lifetime, and I have been blessed by having people call me on it. I appreciate that they've called me on it in nice ways. And I continue to think about how to use words appropriately. And when I don't, or if I make a mistake, apologizing and learning from that is really critical. When we talk about race issues in our country today, sometimes people don't say the right thing, or use a word that may be antiquated, or outdated, or, the other day, my staff was talking a lot about, what language do we use? The term Hispanic or Latino or Latinx. And again, I think that, my comment was, why don't we reach out and get some opinions from folks that this is important, because the words do matter, and we have to come up with a strategy. Culture matters. We've seen that, across the board, and we've certainly seen that as it relates to, how I'll just say that the prejudice and discrimination about mental illness cuts across varying cultures. We have to address those things. We understand different geography, ages, those are all cultural aspects. And so we have to take those into considerations as we're thinking through what we want to do most. And of course, family matters. And that to me sums up a lot about systems of care. And finally, truth matters. And telling, whether it's telling truth to power or to staff or whoever it is, that we're better off by being honest and upfront and addressing those issues head on, rather than trying to brush them under the rug. So those are important things. And so I learned about what matters most. So if you can't be matter of fact, you should always use your gray matter in order to matter. And that's just my nice little way of saying we got to think these things through every day, all the time. And again, it doesn't mean we don't make mistakes. It means that we acknowledge those mistakes and then we address them appropriately, because really our field and what we're trying to do is to bring people together, build consensus, and care about each other. I also learned that using your bully pulpit doesn't mean you have to be a big bully. And I mean, truly, and I look back at my days in government and even in my current job at the Hackett Center and the agency. And, I've often had a bully pulpit from which to share and do things. And it doesn't mean, that I need to be mean about it. And I think that we have to watch ourselves. What is it? You got to check yourself before you wreck yourself. And that is a real critical piece, I think, to our puzzle, strengths-based, focusing on being the aspirin. These are the things that will help us to take the next step. And within your own comfort level, sometimes you have to cause a stir to stir a cause. And I really do think that, we have great examples, whether it's the work that we did at SAMHSA around issues related to young people identified as LGBTQ, and focusing on, like telling the government, this was even, back in various administrations, that this is important because our young people that identify as LGBTQ are in terms of high levels of suicidal ideation and depression. And this is a public health issue. And remember, if we're taking that public health approach, we sometimes have to cause that stir if we're going to make a difference. And of course, everyone has to understand that that's in the context of how comfortable they are with their own risk. I will say that my risk comfort level has actually gotten better as I've gotten older. And at the same time, it doesn't mean that I do things nasty. It means that I will push the envelope on these things, because causing a stir is sometimes, depending on that level, important if you're going to stir the cause. I also think it's important to remember that the grass is always greener where you plant green grass. So it's not on the other side of the hill, folks. It's because we don't know what's on the other side of the hill, or who's coming next, or what the next thing's going to be. So we, incumbent upon us to just say, all right, if I want the grass to be greener, then I need to plant that green grass myself. So how do we do that? What are the strategies, the technical adaptations that we must use in order to think through how we want to have the grass growing where we are, and not think about it just being, well, if we only did this on the other side, it would be better. Well, I can't promise that. So let's work on it right here, right now, and make a difference. I also learned that stealing someone else's thunder can come back to you thunderously. And what I mean by that is really that it's about sharing credit, it's about sharing responsibility, it's about sharing accountability. And I'll just say this, in government, this is a pretty easy thing to do. Somebody did some work, and of course, somebody wants to take credit for it. It's all well and good. And sometimes it doesn't bother me. But for me personally, I think it's important to support other people, because rather than it coming back to me thunderously, when I do that and I support other people and give them praise and credit and other things like that, then ultimately we all win. And so being careful to understand when and where that happens. It's a level of integrity that I have found across many, organizations, including government. And at the same time, I've also seen it happen the other way. And then, people will resent that and be upset about it. So, that's why, folks, you'll see a lot of my written materials has a number of authors on it, because we've worked together on this. And that, to me, is a real critical piece. I also think it's important to learn that when you bite off more than you can chew, you either got to chew faster or you got to spit some out. Truthfully, you can't, we're all pressed for time, energy, et cetera. And so this is a critical piece. I won't belabor it. You know yourselves that sometimes we just can't chew faster, and we have to prioritize. And sometimes that's a tough conversation. We also need to remember that if you heard it through the grapevine, it better be from Creedence Clearwater Revival, okay? Because if you've heard it from the grapevine, I don't know about you all, but it gets, the game of telephone, it gets a whole other, impact or statements that are being made. You don't know exactly what it is. So you got to find out what the real truth is. So those of you who are contemporaries, I hope you appreciate my metaphor for Creedence Clearwater Revival. I've also learned that when you speak of the devil, you can be sure that the devil is speaking about you. So in other words, I think it's important that we not speak negatively of folks, being really careful, whether it's, just at the water cooler or whatever, because if that happens, if you're doing it, I bet dollars to donuts, as my mom used to say, that other people are speaking about you. So it's just a thing that I've learned around being strengths-based and again, not speaking of the devil, because the devil has a way of finding you. And then I've also learned the 4 H's. Be humble, be honest, be healing, and be human. That's who we are. So 4H, I love that. And that we actually did some work with them on mental health issues when we were at SAMHSA, combining some of the 4H leadership. And I really learned from them, about honesty and all of those things. And so that is a way that leaders at all levels can really be identified as somebody who they want, folks want to both follow, and also who can follow others, because sometimes being a good leader is also being a good follower. And most importantly, through this whole process, you got to keep learning. And I love Spider-Man. Many of you know that the spider guy is a favorite, and so this is what we have to do going forward. So with that said, I've left about 16 minutes here. Please, if you have not connected with the Hackett Center, we are on Twitter at Hackett Center, on Facebook, on LinkedIn, and then of course, please stay connected with me. I really would appreciate linking with me on Twitter or with LinkedIn, especially now that I've moved on into other roles, that it's always good to hear from my colleagues from across the country related to systems of care. So thank you so much for this opportunity, and I'm going to stop sharing my screen and go back to, here we are. Right, over to you, Michelle Zabel.
Well, I think this is for both of us, right?
Okay.
So thank you so much, Gary. It's so good to be with you in this space and hear from you again. So I pulled 3 questions from the chat that because we did go ahead and answer a few things. And just as a reminder, Joyce Sebian and others provided many resources, and all of those will be posted to the when we post this and additional resources in the next 24 hours, I think. So I got 3 questions for you, and I'm here as your backup if you need help. So, which I'm sure you won't. So the first question comes from Jeff Vanderplug, which I was super excited to see that he joined us today. Can you talk to us, Gary, a little bit more about approaches to assessing needs and acuity so that system of care personnel can appropriately distinguish between those that need inpatient or PRTF versus those who can be safely and effectively maintained in homes and communities without high-end care?
Wow, that's a great question. And it's also, let me add my appreciation, Jeff, to see you, and congratulations on all the great work up in Connecticut. So I think many of you know that there are a number of validated tools and measures that can be used to help in the process. And of course, I'll space out on them at the moment, but I remember that we had talked about the roles, or the living environment scale, or in terms of residential or inpatient unit, or the our friends at the American Academy of Child and Adolescent Psychiatry have something that's the Child and Adolescent Service System Scale, the CASI. There are a number of these kinds of approaches. I know that I think it was Michigan that was using the CAFIS across the board, and trying to use that to identify the various potential levels or acuity needs. Sort of thing, or the CANs from John Lyons and our colleagues. And, I mean, these are just all examples of how to do that. And so there are probably others that I'm forgetting. And I think that the great news is that people like Jeff, or our technical assistance centers that we have, Michelle's group and others, have probably lists of these things. I focus also on things like the trauma and grief and validated measures to address the level of trauma and grief that we have, because we've learned, actually bereavement, I learned this from our Trauma and Grief Center, is the #1 predictor out of all the traumas of negative outcomes. And so, people think about all these other things. The reality is that loss and grief is the number one predictor. So should we not be, looking at measures to address that? So I think that we have to continue working on that to refine these things, especially as we're trying to, divert young people and into the right level of care. So, that's sort of the way I say it. I am noticing that very cool people that I see. Thank you guys for coming. Beresford, I see that, and Pat. Oh my goodness, this is like a old home week. So thank you all so much for coming. We have an.
So I'm gonna keep you focused. I have 2 more questions for you. There's one I did
jump in if you had more. If you had another.
I want to say in the chat that what I did say is that we just during Mental Health Awareness Month launched the online system of care primer. And that was a collaboration of all of the partners from the TA network that we worked on for a number of years together. And module 12, Jeff, has a lot of information about screening and assessment, integration into primary care, the way to help systems design care pathways and use screening tools to interrupt those care pathways. So that traditional usage of inpatient and residential is really challenged to be where and how kids need it and families need it. So I'd encourage people to check out those modules, use it for your staff. And it's all outlined, so you don't actually have to go through all the modules. You can go to sections of the modules if that's what's most helpful to you. So I just wanted to call that out. So there you go, Gary. Joy Sebian actually doesn't have a question. She has a statement, but I want to put an exclamation point to it. So I'm giving you the chance to do that too. So Joyce says, in education, we need to better link comprehensive school mental health systems with systems of care and re-envision school and community partnerships so they foster equity and belonging for all students, including LGBTQ+, students of color, faith groups, and more. Students and families are experiencing racial trauma in many of our schools. And I'm positive you agree with that. I don't know if you want to add anything to that, but I wanted to call it out verbally in the session today.
Thank you. And again, I'm so happy to see Joyce participating, and her comments are always wonderful. I'll add to that, but the Hackett Center has been very focused on helping Texas independent school districts, as an example, and our education service centers. Texas is a pretty big place. The Education Service Center in the greater Houston area serves 1.2 million children. And we help them to craft what we call the Region 4, that's that region, Emotional Wellness Strategic Implementation Plan, which was a strategy that we used to help them think through ways to do both internal and school-linked and external kinds of activities to address student mental health needs. I think a lot of this often has to do with the right kinds of education and training, making sure our teachers are supported. They have such a difficult job. And, last year, I couldn't even imagine what it was like to be a teacher, to have to do virtual training and hybrid learning and all of these things. And it's about helping the education system know where the resources are. Some have enough in-house to do it, some don't. So we need to know where they're at, what the gaps are, again, and then focus on this idea of a multi-tiered system so that we're doing universal supports as well as addressing young people that have, say, mild to moderate symptoms versus those that have such a high acuity level. Joyce has worked really closely with the Bainham Family Foundation, for example, on this concept, and actually Maryland's School Mental Health Institute around the Comprehensive School Mental Health Systems, CSMHS, and also a framework called ISF, which is the Integrated Systems Framework, which allows schools to really create a strategy where they're focusing as best as they can, meeting them where they're at on how to address mental health issues. So the only adding thing I will have to say is that we really do need to not just support our teachers, we need to understand that their jobs and and all the educators' jobs are very difficult, and that's where we got to give mental health away. Why are we, keeping it in an office. Let's go to the school. Let's create a connection between the school and their local mental health agency and do all of those kinds of things. Let's do wellness activities and really focus on this. So anyway, that's the thing that I would want to add. And we're really, my agency, the Hackett Center, is really focused on addressing this all across Houston and even across Texas.
Yeah, and I would just add that through the American Recovery Act and all the block grant and efforts that are, increasing revenues to the states, that we have, most of our states are focused on establishing crisis response models. And so to Joyce's point, the opportunity to reconceptualize what that model looks like in partnership with school and community-based organizations is really important. So for any of the kids leaders that are out there that aren't at tables or aren't participating in any of the forums that are going on in your state around crisis response, I would just really encourage you to tap into that effort, because it's the place where school efforts, community-based efforts, family, peer support efforts kind of all come together and are really important to address equity, police reforms, and a number of other systemic issues that we're all concerned about. So that's my additional plug.
And let me add to that. So, I was with SAMHSA for a long time, and I'm a supporter. I love SAMHSA. And I think in my new role, occasionally I need to call out where, as I would have done internally, SAMHSA just put about $3.5 billion into the two block grants, the mental health block grant and the substance abuse block grant. And they're giving them to states, states are going to have a lot of money, to start addressing post-pandemic mental health issues. And my plug is for all of us to remind SAMHSA that they need to set money aside for children. And this is a real critical piece. It's an argument that now I've had for years. And I understand that it's a challenge to think about how this could work. And if we don't collectively remind our policymakers about these kinds of things, we get short-shrifted. Right. So just remember, as the block grant is coming out, if it's in your state, your block grant is getting an infusion of money, and reach out to the councils and the leadership and remind them that these, at least a fair amount of these dollars need to go to children and adolescents and young adults.
Yes. And in a true effort to be a system of care leader, map the funding that's coming from everywhere, because there's increased match from CMS dollars that will backfill and be able to support for the long run crisis response models. There's money coming into education that most state educations will earmark for crisis response, because we're so deeply worried about how children return to school in the fall. And so this is a moment where system of care leaders can really be pivotal in the conversation, because the money is in all the pots that is out there, and people need to align and create strong models that do what Joyce said, align school-based and community-based service delivery approaches to help kids and families. So we have a couple minutes, and I'm going to ask you one more question quickly. Can you address anything that you can think of about system of care evolving to support the needs of children and youth who are immigrants?
So
refugees, my bad.
So number one, I would start by saying that systems of care has always addressed the needs of undocumented young people and their families.
Yes.
There was never one time when I got a request, from a state or a locality about how to do this that I said no, ever. And the reality about that is we are here to serve everyone. I think of the Hard Rock Cafe model: love all, serve all. And by doing that, I think that, so that's the first. It's a philosophy. And I would just argue, I used to say that, I'd rather ask for, forgiveness around this issue, than permission, because I would rather get in trouble for providing services and making something good happen for a child and family than by being afraid not to. So that's number one. Number two is that, we're dealing with this right now, right here in Texas, in terms of the immigration issues. And systems of care is designed to help all of the people, wrap services around a particular young person and their family. So that I would just say that systems of care is the right approach in these situations. We have many challenges, and these young people have been through tremendous trauma, often with grief attached to it, as they've lost parents or loved ones, that they can't be with parents or loved ones, all of these things. And we have to attend to this. So my statement would be, just do it.
Good.
Nike.
Okay, we're getting nudged to wrap it up. So there's one question here about fully employing youth and families in the process of partnering with child serving system, and partnership meaning shared authority and responsibility. I know that you have lived your career pushing that agenda and ensuring that money has been allocated and that policymakers are responsible to have that kind of approach in all they do. So I will, I'll let you get into the chat and respond if you want to say more, but we have 1 minute and I got a text to say, wrap this up. So
it's awesome.
Thank you, Gary.
Thank you for that. And we cannot do this without the complete involvement of our families and our young people. So whatever it takes to get to the table and have a meaningful role. And if there's anything I can ever do to help with that, please count on me. And thank you all for remaining with me during this period of time, for indulging me on sharing some of my own personal lessons and this great opportunity. And I wish you all the very best.
And let me just say, we love you, Gary. Thank you for presenting today. Thank you for our interpreters, Levy and John. Thank you for all of you spending time with us. And if you haven't registered for the workshops that are following after the break at 3:30, it's not too late. You can do that. The registration link is in the chat. We just want to ask you quickly, please stop and do the evaluation for us. It's so helpful. We do take your feedback seriously, and it'll shape upcoming series that we host. And as a reminder, like I said in the opening video, we are switching to our summer model, so you can take us wherever you go this summer. And I hope all of you are getting a break and a vacation. July and August workshops are released at the beginning of the month. You can, they'll be available to you all month long. So I encourage you to actually stop and pay attention to them when you have time. And the links to the workshops on the website is also posted in the chat. So thank you. It was nice to see all these names. It was great to be with everybody, and we look forward to